Lydia, this has been amazing. Thank you so much. The audience in our Q&A has been really, really engaged. They've just been all over the chat. So this has been phenomenal. I know folks are going, wow, I've taken in a lot here today. But I think what is, for me, one of the things that was just kind of most surprising to me is I watch a preposterous amount of movies and television. I mean, it is just disturbing, as my spouse would say. I mean, just all the time. I mean, so many different genres, everything. And I was just boggled when you asked the question about, okay, let's have some positive depictions, BIPOC or not. Who are some positive depictions of the folks who are like not associated with criminal behavior, who are going through recovery? And I'm my Rolodex is spinning frantically in my head, my inner IMDb, and I'm having such a hard time coming up with examples. I mean, it's such a were there some that you like to mention, Lydia, that didn't get brought up that are out there that you like to refer to?
There's so many that we didn't talk about that are often useful. I'll just highlight one that I think is really useful for us to pay attention to. Like Paul, I just watch so much television and I watch so many movies, and I think about it. There are things that are sort of like embedded as I move through the world. And one of my most recent favorite television shows is Sex Education, which I just think is phenomenal. They do this incredible job of representation. They do an amazing job of having diverse characters. They do an amazing job of talking about gender and sexual identity diversity. They do an incredible job of trans representation. And the whole show really is about motherhood. The whole show, in many ways, it's called Sex Education, but it's about teenagers. And oddly enough, in many ways, it's when you boil it all down, the show is about mothering and motherhood. And so what really stands out to me in Sex Education is that they do this incredible job of representation, but they have one representation of addiction on Sex Education. And it just jumps out to me whenever I think of the show, because it's such a played out trope. The one depiction in Sex Education is of a mother, because the show turns out is actually about motherhood. And she shows up roughly once a season, is incredibly selfish, always returns to using. She brings in every stigmatized narrative that we see in the media. She shows up once a season to ruin her kids' lives. She's incredibly selfish, and then she can't recover. And I think it's just it's so telling about how deep stigma around substance use disorders is in our culture, when this TV show does such an incredible job of representation in so many other places. But what the show is about mothering, and there's a mother who just has the most stigmatized television trope of addiction that you could generate. So that's one I always want to highlight. If you've watched Sex Education, you know exactly what I'm talking about. And if you plan to watch it, it's an incredible show. Please watch it, but watch for that, because it's really big and it's really central in the way that the story unfolds.
And we've got a couple of questions that have come in here too.
I'd love to hear your thoughts on tough love. I know there are families who have zero contact with their loved ones who use substances as a matter of self-protection.
Yeah, that's such a good question, and it's so incredibly nuanced. So the question is, what's your thinking about tough love? And so I want to answer this in two sort of intertwined ways. And I want to start just by talking about the medical evidence. So the whole idea of tough love when it comes to substance use disorders really started to be promoted in the early 1980s. And its promotion was not based on sort of medical evidence or what even we think is best practices of the day. It started in the setting of two parents who found that tough love is what helped their kiddo recover from a substance use disorder. And these two parents started to travel around the country and talk a little bit about what had worked for them. And they talked a lot about tough love. And that's really where this idea of tough love and substance use disorders comes from. That's the genesis of it. And I just want you guys to think for a second, if I told you that some parents traveled around the country talking about a medical treatment not based in the evidence, but what worked for them, and then charged money for tickets for this review of what worked for them and their family, but might also work for you, and here's how you can do it, what would we call those folks today? It worked for them. What would we call them today? We might call them like motivational speakers, but we might find some of what they have to offer very useful. The idea of sharing your lived experience and what was beneficial for you to an audience of people with similar lived experience, incredibly powerful. That's powerful stuff. And it doesn't guide treatment planning. It doesn't guide treatment planning, and it's actually not based in the medical evidence. And so then we have to go and say, okay, what does the medical evidence say? And there's actually some pretty evidence-based ways that family members can interact with and support people in their families who are using substances. It's called the CRAFT method. There's a great book on it called How to Use Science and Kindness. Ooh, I can't remember the exact words. How to use science and kindness for something having to do with substance use disorders. It's evidence-based, it's written for families, incredibly useful. The method is called the CRAFT method. And I also want to highlight that anytime someone is engaging in behavior that crosses your personal boundaries, you get to do what you need to do to feel safe, which is incredibly useful in the setting of families, but not incredibly useful in a medical setting. But it is, well, let me say this differently. It's useful in a medical setting because it's the same thing. In a medical setting, if someone's engaging in behaviors, and it may be related to their substance use or not, and those behaviors cross a boundary as what is appropriate for that facility, then that person might not be invited back to the facility or might not get those services anymore. But it shouldn't be predicated just on the substances. It's about behavior. It's not about what substances someone is using, it's about behaviors that the person is engaging with. If you need to have clear boundaries, set clear boundaries. If you want to engage in evidence-based modalities for how to support family members, turns out tough love isn't actually the most evidence-based. The CRAFT method is, and that tough love idea comes from a time period in the early 80s in which some parents were sharing what had worked for them. And it became lore. It's baked into our cultural narrative. Tough love is how you help people recover. It's part of that structural stigma we talked about. It's baked into who we think people with substance use disorders are and what we need to do to help them. It's not based in the evidence.
Excellent. Here's a comment and a question together. One barrier to addressing stigma is that people may think there's nothing we can do to reduce stigma, as it's so broad and so pervasive. So any recommendations, Lydia, on how an organization can create internal momentum to help address stigma?
Yeah, I love that question so much. This question of how do we internally address stigma when it feels so big? And you might remember that we talked about the 3 layers of stigma, and there's the structural stigma that in many ways sort of provides the basis for the other layers of stigma. And tending to structural stigma is not something that you or I necessarily can destroy today. That's not something that you and I over the next half an hour can tend to. And so it can feel really, really big. It can feel pervasive. It can feel like things it can feel like things that we don't have any control over. And I also want to push back because that cultural narrative changes over time with a lot of soft guidance. Culture change can happen. It changes over time with a lot of soft guidance. And depending on your role in an organization, you're going to have fewer or more ways of providing that sort of cultural guidance that decreases stigma. Tiny things like modeling appropriate language can be incredibly useful. Hanging up a flyer, documenting appropriately in your medical charts can be incredibly useful. Pushing back gently and modeling appropriate narratives around substance use disorders, what causes them, and how people with substance use disorders get better can be incredibly useful. Asking people gently, oh, that's such an interesting way to think about it. Can you show me some medical evidence where that is useful in the treatment of substance use disorders can be incredibly useful. Things that tend to not be useful when you're working on culture change are anything that involves shaming. And this probably makes sense because we know that shame doesn't help in behavior change, right? We've actually reviewed this today. If what you want is for people to change their behavior, shame is never the answer. So when we're trying to promote sort of soft culture change, we are going to model, we are going to offer alternatives, we are going to model alternatives, and we're going to push back really gently. Hey, tell me more about when you said this, what did you mean? I think of it like this because I think of this piece of medical literature. So the idea here is to, in many ways, utilize those skills that we utilize in motivational interviewing at an organizational level. We don't shame people, we don't judge people, we offer alternatives, and we invite them in to new narrative creation.
Thank you so much. And then this next question, I think maybe is kind of a corollary to that. Do you have any resources or recommendations for how we can document care of our patients in ways that highlight the research about shame and stigma?
This is such a good question, and I'm going to struggle to come up with ways that we can all do this, but I've seen some really exciting things. Well, no, I can highlight ways we can all do this. There's been some really cool things that I've seen historically at sort of a broader systems level. For example, at OHSU, they actually have a chart pop up whenever someone has a substance use disorder diagnosis. They have a chart pop up that will say evidence-based language is XYZ, to just help people remember that there are evidence-based ways of talking about substance use disorders, and then there are more stigmatized ways of talking about substance use disorders. And that's at a system-wide level. But I also really love it. I mean, it's a system-wide level of saying like, hey, stigma's real, it influences our medical care, let's tend to it, and let's talk about it in these really non-stigmatized ways. And then I think all of us can model sort of trauma-informed, strengths-based documentation. And, you know, we can do things that just really concretely, you know, call out, like, I did not do a urine drug screen today, might be the norm, but this patient may experience it as stigmatizing, and we actually don't have any medical evidence that I am in need of a urine drug screen today. That is a larger sort of systems-based thing, talking and thinking about when we do urine drug screens. That's very much sort of an administrative thing to think about. And we can always change the way that we are individually documenting for each patient. So I hope that answers the question. Feel free to get more specific on that question if you'd like to, but hopefully that answers a little bit. Just know that it's always appropriate to justify clinical decision making by talking about destigmatization, what propels stigma, what decreases stigma, etc.
What that seems like it suggests to me is it's almost like using your documentation or your chart notes to be the equivalent of what you were saying, where you're like modeling, right? It's kind of like you're leaving a little touchstone for the next person to sort of say, oh, wow, look at what this interaction was like. And you're not correcting somebody. Yep. You know, you're leading by example, and you're doing it in a positive kind of neutral way.
Yeah, absolutely.
Modeling.
Yep.
And then you were just talking about examples too, and Sabrina added more about the power of stories, you know, because we talked a lot about how media characters influence the way we think, right? We can also use stories to change stigma by giving new, you know, maybe more positive shared narratives.
Yeah, I love that, Sabrina. Thank you so much for talking about the ways that we can share stories and sort of highlighting the ways we can share stories to decrease stigma. I actually got to speak at a conference, I want to say it was 2 weeks ago now, up in Everett, Washington, and the keynote was Ryan Hampton, who's sort of a nationally known speaker. He thinks and talks a lot about legislation change related to substance use disorders. So he's done some like national consulting work and has worked in the White House and in the setting of things like getting Narcan to be over the counter, for example. And his whole talk actually was really beautiful and meaningful. His whole talk was on the power of storytelling as something that reduces stigma. He did an incredible job of it. And I think you're really just highlighting what I learned from him, which is just the telling stories of recovery, telling stories of persistent substance use that don't include recovery, but are not stigmatizing. All of those things are so powerful in helping to change these sort of broader cultural narratives that we carry with us about substance use disorders. And I think the sort of tiny version of that is highlighting people with lived experience of substance use disorders every time we get a chance. For example, Robert Ashford has done some of this really high quality research around language that propels people to engage and or repels people and increases stigma. Doing that kind of stuff is just so important. Highlighting people with lived experience. And I also want to highlight here that when we highlight people with lived experience, we don't just highlight people in recovery. We highlight people with living and lived experience. That every time we can include someone who's using substances actively in a conversation helps us to dispel these myths about who people are that use substances. I have so many people in my life that actively use substances. Some of them have problematic relationships with substances, and some of them don't. And I always learn new and important things from talking to people that are utilizing substances. So I try to be in touch with the Portland Drug Users Union and try to support their work as often as possible. And I learn an incredible amount from them. They're useful for me, and talking about their existence decreases stigma for people that are utilizing substances.
I think, just looking at the time, we've got time for like just a couple more questions real quickly on here. One that I thought was really interesting was a person was asking and kind of being curious if you see more stigma as being more of an issue in this country compared to like other countries at all. And they're mentioning, the pervasive idea of willpower and the pulling up by your bootstraps myth, how it's, so deeply embedded. And I think they're making the point that it becomes a foundation for blaming people quite a bit.
I think that is such a good question. And I have to be fully honest and say, I don't know. I've never lived in another country for longer than a year and really engaged in their media and really thought about how we tell these stories. So I got to be fully honest and say, I don't know. And what we know about the way in which our country was sort of first developed culturally, it's incredibly individualistic, right? So we are infused with sort of capitalistic notions of individualism, and we have this we have a culture that's very, very individualistic. And so I think that one can assume that our culture is going to be far more invested in sort of personal, individual narratives of addiction and recovery than other places. What we know about what causes addiction is that it's often very structural. What we know about what causes addiction is it's structural, but we have a personal narrative. We have a cultural narrative that it's a personal failing in our country. And then we also assume that recovery is something that's about personal advancement and something that we were able to do. But hey, guess what? Recovery is just as structural as addiction is. When I had a really good friend who returned to using about 2 years ago and flew to Hawaii for 3 months to engage in recovery services, but the bulk of my patients have to wait in line every morning out front of a place to get services. They have to wait in line while they're actively using and houseless for 2 weeks. I think it really tells us that recovery and substance use are way more structural than we often talk about. And it's because we have this cultural narrative that we are individuals who pull ourselves up by our bootstraps. But it turns out we're all existing inside these big invisible structures, and that those things actually impact our health and wellness far more than individual factors ever could.
And I think we have one more question I want to just get in here because I think it'll help. A couple of questions that were coming together about resources. Somebody was making a wonderful suggestion or asking, is any state-sponsored programs about getting stigma education like this in schools for teachers and students? And then kind of a corollary to that I think speaks to resources quite a bit was just the general notion of what's the best way of finding each other to refer our clients to other trauma-informed providers. What would you recommend on those two?
Oh, those are huge questions. I know I only have 3 minutes left, so I will try to make it quick. Okay, in terms of resources pulling sort of anti-stigma work into the public education system and the K through 12 system, I don't know of I don't know directly of like, oh, it's this department. If Sheila Johnson is on the call, Sheila might be able to speak to this, because I do know that there's starting to be work to sort of bring anti-stigma education around substances into the K through 12 world. I think it's something that we're going to see and hear about a lot more, but I don't know of direct resources right now. And then in terms of finding other trauma-informed providers, I think that one of the best things we can do is just look for other providers that identify as utilizing harm reduction in their approach. What I have found is that people that are on board with harm reduction sort of secondarily are pretty, there are providers who are tending a lot to stigma and often want to engage in a very non-paternalistic way with their clients. So even more than trauma-informed care, when I'm thinking about like who I think is going to be a non-stigmatized, non-paternalistic provider of substance use disorder care, I often will look for folks that have the influence of harm reduction in their care models and their care styles.
Thank you. Thanks for tackling that with such limited time that we had here, Lydia. So I appreciate that very much. You are a phenomenal resource for our community, and any chance that we have to be able to learn from you and spend some time together is pretty amazing. I'm just going to wrap us up real quickly here, folks, and then send us all on our way at the top of the hour. Again, like I mentioned at the top of the webcast this morning, you're going to be getting an email if you registered that will have things like copies of the slides, a brief survey to fill out just to record your attendance so that we can get you whatever kind of CME or CEU credit that you need. And you'll have try to get that done the next couple of days, because we'd love to be able to send those out to everybody early next week. Want to just briefly tell you, this is our last Meds Ed session of 2024, but we have all kinds of stuff coming your way in the year ahead here. Quite a few things to titillate you with as we're promoting things there. I believe, if my conversation is correct, we've talked about like January reconvening with our friend Lydia here to talk about some difficult conversations involving deprescribing. And I think that that's going to be a very excellent opportunity here. Just brief preview of other things that are in development we're talking about. We're going to be talking about palliative support in advanced illness. And one that I'm very excited about, that we're still developing with some partners up at OHSU, is just July, the Surgeon General came out and declared, I think well overdue, that gun violence is a public health crisis in our country. And so we're pulling together some experts to come talk about that in a very open manner, to be able to get as much attention around that in a very positive way as we can. So look for information and enrollment opportunities for all those sessions here as soon as we're able to turn the corner towards the end of the year. So really want to, again, express our unbridled thanks to Lydia for spending so much time with us today and being so open as a resource for us and as an educator. We just are so lucky to have you in our community. And to everyone in our audience, thank you so much for spending time with us. And thanks for everything you do for bringing so much care and hope to our community here in Oregon and beyond. Have a great day. We'll see you soon. Be well.